And thanks for coming. This presentation is a lot about you and finding answers to issues that you might be having. So the format of the presentation is fairly straightforward. I'm going to introduce a little bit about myself and the clinic so that you can understand our perspective and why we're here and our interest in reaching out to the community. And then I'll ask folks here what they might be experiencing so I can be sure to have information that's pertinent to issues that are presenting to you. And then we'll talk about some contributing factors to shoulder pain that are oftentimes overlooked. We'll talk about some research and developing understanding of moving from old understanding of how shoulders get better and improvement to more modern understanding of it using evidence. We'll have a chance to have a opportunity to see we call a 5-minute miracle, and that is an opportunity for you to see how I might evaluate and assess and treat somebody who has a shoulder problem.
I thought it was knees.
Yes, I did too.
Is it
Are you on the
knees?
same page?
It's knee, yeah.
It's knees.
It's okay. I mean, we have shoulders.
You fixed my shoulder.
Thank you, I appreciate it. We're doing this month. We're doing like 4 presentations in 3 weeks. So for problem knees, similar theory or similar approaches for that. So thank you for correcting me. I would have figured it out eventually and really confused at some point. So thanks. A couple things. There's a restroom through this door, the second door on the right. There's also a restroom through this door and the next door and the first right. So by all means, if you have a hard time hearing me, let me know. Sometimes my voice can trail off. And we'll get started. So, okay, so relieving your painful knee without unnecessary medications, drugs, and surgeries.
Well, let me get this straight. You want us to use our shoulder, right?
Right? Absolutely.
To get that knee pain. Yeah.
That's right. So our mission here at Physical Achievement Center is to help people improve their lives and achieve greater mobility and strength for their active life without medication, drugs, or surgery, even when nothing else has worked. I've had the pleasure of working clinically for over 30 years, nearly all of those in Oshkosh, and had an opportunity to train as a fellow in physical therapy, which means I studied in-depth the research and clinical applications of pain relief from head to toe, and been around for a while, so I have an opportunity to help a few cases. There's other providers here as well. Dr. Rebecca's on our team. She's been with us for almost 2 years now. She's got over 10 years of clinical experience, and she's got a specialty training in applied functional movement patterns. All of the clinicians went to go learn more about that just a few weeks ago in Chicago with her. She's helped a number of folks. She's been in practice for a while. She was voted the Physical Therapist of the Year in Wisconsin in 2019. And it's easy to understand why, because when my patients go see her, they forget about me long after they see her. So she does nice work. She's a great personality. Dr. Jessica is our newest doctor of physical therapy. She's been with us for about 7 months now. Specialty training in all things upper and lower body as well. We also have Gina as a physical therapist assistant, and she is specially trained in pain relief and sports recovery massage. She's a certified spine specialist, certified upper extremity specialist. So got a good treatment team. So that's a bit about the team. So why was Physical Achievement Center started? Well, so I came out of fellowship training and I looked around and I said there's a wide gap between what's possible for people and all their options and what's practically offered to individuals when they go see their primary care providers or specialists. I've been in the community for a long time, so I kept hearing stories from my family, friends, and neighbors about what people aren't being offered, and my head nearly wanted to explode. So I decided that the way for me to have conversations to be inclusive of all options needed to do that in the context of a private practice that didn't have any oversight from administrative or other specialists, so we can have straightforward and frank conversations about all things as it relates to getting people well. We're here to help people make better healthcare decisions, and one of the key features that we think about is this term called evidence-based practice. Anybody ever heard of that? Evidence-based practice is this confluence of the center of it is the patient, right? What is the patient's perspective and preference? And then that's combined with what is the specialty training of the individual in front of them? And then the third piece is does the research support for effective intervention? Well, if the patient's at the center of that, the first thing they need to have is all their options. And what we see routinely is individuals aren't provided all the options. I can't explain why, even though they're evidence-based, and the research is more and more supporting of that. If you don't know all your options, it's hard to make a really good informed decision. So that's our role here. And we want people to avoid unnecessary medications and drugs and surgeries. And this is some of the rest of the team here. We need to update our picture. We got a couple new team members. Maybe we'll get an ugly Christmas sweater picture in there pretty soon. So what I'm interested in here is hearing about your problem knee, and if you would just provide some input as to perhaps your name and what you're primarily concerned about with your problem knee. So nice. I mean, it's a nice smattering of stuff. I'm really excited about being able to talk about knees because there's evolving research actually. This last week I came across some great research that I'm going to share with you about NSAIDs, about cortisone injections, and how to put some of that in perspective. We don't have anything formally about knee replacements that haven't gone as planned, but by the end of the discussion of the contributing factors to knee pain, we may have to add, knee replacements that didn't work out. Like, we don't always know, but there's lots of factors that contribute to knee troubles, first of all, that you'll find out. And you'll kind of understand our perspective on how we look at things. We think things need to be much more comprehensive rather than looking at one narrow thing, right? I mean, I think that's a big mistake. So that'll be a common theme. So you can kind of listen to that. Erica, when you have a chance, if you could bring the knee model, because we'll probably play with that sooner than later, if you could. So, yeah, I mean, literally, my head explodes when someone comes to me and they hear something from their providers that says, well, what do you expect? It's your age.
Yeah.
The other knee's the same age, right? First of all. And second of all, if you can't help somebody, let them know. Or if you don't know, let them know. But I think the presumption that whatever birthday you have means you have to live with stuff, I think is not acceptable. Less than a week, I'm going to be 55. Like, I don't want to be hearing that crap at any age. Like, nor should anybody have to hear that, right? There are obvious age-related changes, but we're not going to disrespect people and say, what do you expect at your age? There are times when, there's obvious changes that can occur over time that are real. I'm not denying that, but that's a cop-out, right? In my opinion, you just have to live with it. Or other things we hear is just, take some ibuprofen, take some NSAIDs, that sort of thing. So I think let's talk about a couple things first of all. So the cool thing about some recent research that just came out, and I was trying to digest some of that, and I'll dive into what they actually said there. So there's an international group of arthritis experts. So I'm going to ask a question, your quick survey. What's the number one recommendation of arthritis experts, even as it pertains to knees all over the world?
Stay active.
Stay active, right?
Yeah,
Okay,
keep moving.
for sure.
Stay active.
Stay active. The question is, what do you do when you hurt, right?
Mhm.
Like, do I walk? Do I stretch? Do I lift weights? What do I do, right? So that's a big question, right? So that's interesting. The second thing is, do you think there's any potential side effects as it occurs with knees, specifically for knees, with injections, like cortisone injections?
Yes.
Yeah.
Yes, I've
What's-
heard
what-
that it breaks down the bone after a while, that it actually isn't good. Yes, it does pain. It's a Band-Aid. It's not gonna last. It's something
So-
that's injected.
Right. So you said something. You said it breaks down the bone tissue.
Breaks down
Yeah,
the bone
regrettably it does. I mean, research is supporting that, right? I mean, it's
Mm-hmm.
a very potent. So cortisone injections, as most people probably realize, quick pop of corticosteroid in the knee, and it can dramatically lower pain and inflammation abruptly, right?
Mhm.
Typically, that's where people's treatment stops.
Mhm.
Like, just go live with your life now, and well, there's something that probably brought that knee to some problems. Let's see about maybe if you're going to have that treatment, why not go to an expert and find out what else can be done to make that area move better. We'll talk about that a little bit. But that's, certainly enough research supports that actually the underlying bone tissue starts to degrade a little bit more. I don't say that to scare people. I'm just saying that's what the research shows,
Yeah,
right?
it's the truth.
Thins out connective tissue. I remember when I was working with a young lady who had, she was in a state institution and she had lots of injections in and around her ankle for lots of ankle pain. And her Achilles tendon on the side that had a lot of injections, and that wasn't the painful part, was literally half the width. Like you could feel your Achilles tendon. It's probably about the width of your finger. Hers was half. Young, active, upper 20-year-old woman, right? So it does weaken tissues. Some research supports the fact that you may be more likely to need a knee replacement if you have a series of cortisone injections, right? It's built into the formula that you can only have 3, and they should be spaced apart because they know that. Like that's the way it is. And I'm not begrudging anybody who does that or has that. It's just people should know about those sort of things, in my opinion, right? So non-steroidal anti-inflammatories, ibuprofens,
Kidneys,
so kidneys, side effects,
I've only got 2
Liver.
of them. Yeah.
liver,
Liver.
heart disease, right?
Yeah.
Well, and those things are well understood, right? But and I think occasional use of that's one thing, but we know a lot of people who pop them on a regular basis, right? Like if you're doing that, like you should know, right? But this research that recently came out showed that it also contributes to degrading of the joint tissue, like the exact opposite of what you'd think of, and that's the first time I've ever seen that.
Wow.
So I don't know if we'll see other research that supports that, but this international group uncovered a significant amount of research to support that. So that's kind of interesting. So those things aren't necessarily innocuous, right? They're not necessarily just, they can help. They may have some side effects that I think are worthwhile considering. So none of you are making big mistakes with your knee pain when it comes to ignoring it, right? What's the biggest mistakes people with knee pain can make? Ignore it. You guys are here. You guys are educating yourself, trying to stay active. If you let that stick around for a longer period of time, you can just adaptations that can occur above and below your leg and with your walking. So you want to address it sooner than later. Second mistake that people make with knee pain is masking it as one solution only with the NSAIDs. We talked about the over-the-counter medications, braces, gels, creams, prescription NSAIDs, and especially muscle relaxant and opioids. I was in healthcare when the build-up to the opioid demand was there, where pain was to be assessed and treated aggressively, and then the solution came along like, oh, here are these opioids. They're safe and effective for long-term pain. Are opioids safe and effective for long-term pain?
Absolutely not.
They're neither, right? We don't know who's going to become addicted to them. There's no profile that you can predict. You can be any age, any type of occupation, any type of personality, right? There's no way to predict. And number 2, it can actually make your pain worse, right? And muscle relaxants aren't the way to go long-term either. They're a strong central nervous system depressant. Big one, another mistake you can make is ignore comprehensive treatment for all aspects of your knee pain. We'll talk about what comprehensive treatment might look like and why that's important. And then looking at a single solution to your knee pain and weakness, even in those cases where surgery is recommended, your quality orthopedist will work closely with physical therapy and encourage that so that they get maximum recovery after that. All right, so questions so far? we're going to cover some basic anatomy of the knee. This happens to be a right knee. And this is your upper leg bone called your femur. This is your lower larger leg bone on the inside called your tibia. The outer leg bone is called your fibula. You also have another bone that's called your kneecap. We call patella. We gotta have fancy words for things, right? That patella sits on the bottom of your quadricep muscle, your front thigh muscle, and there's a tendon that connects your quadricep muscle to the kneecap, just above your kneecap. And then below the kneecap where we tap to test your reflexes, that's this area here, that's a ligament. It's very similar connective tissue. A tendon connects bone to muscle. So this would be a tendon down here. Connecting bone to bone is a ligament. Between here are a series of ligaments. So on the outside ligament here, that's your lateral collateral ligament. And this one on the inside is your medial collateral ligament. That just speaks to the location of it. If you're going to strain one of these ligaments, the medial collateral ligament is a painful one to strain, but most people recover pretty well from that. As we open the knee up, and I'm going to pass this around, you can pull this kneecap to the side. This is pretty tough. You're going to see two additional ligaments in there. Those are your cruciate ligaments. Cruciate just basically means cross. The one in front is called the anterior cruciate ligament, or ACL. And the one in back is called the posterior cruciate ligament, or the PCL. There's a common sports injury that the knee is twisted inward, forward, and you get a wide variety of injuries there. Oftentimes the medial collateral ligament, a meniscus strain in the ACL. Individuals who have lots of looseness in their knee after a sports injury might have some laxity in that ACL joint. It's one of the times when I think there should be a strong consideration for fixating that or having a surgery fix to that if that kneecap is sliding around a lot. So one of the things you'll notice about this knee joint here is from the side, the upper leg bone is kind of curved. The lower leg bone, if we pull up this tissue here, which is your meniscus, is relatively flat. So to make a little more peace between a rounded surface and a flat surface, we're blessed with what's called a meniscus, right? Anytime you hear some of these terms, it usually sounds bad. People say, oh, my meniscus is degenerative, or it's got a tear in it, that sort of thing. But the meniscus is simply like a space washer that increases the contact area of the upper bone to the lower bone between the two bones there. The back of the lower leg has a strong calf muscle that comes up, and part of it does cross the knee, so that provides some control for the knee. There's your front thigh muscle. Your hamstring muscles contributes to stability, the back thigh muscles as well. So that's kind of the regional anatomy of the knee joint. Interesting thing is here, the outer leg bone does have a part to play. There's a little bit of motion. This model does not show motion. It shows it's fixed. But there's motion that occurs by your fibula, so when you point your toes up and down, that bone slides up a little bit and also gives a little bit in movement and can contribute to more comfortable movement. If it's too stiff, we want to loosen that up to get things moving better. So that's the basic anatomy. I'll pass this around. I'll see if we missed any discussions here on the slide, but the slide shows a front view here, just like you can see. And this is kind of a side slice view. So there's a rounded bone of your upper leg, the flattened portion of your lower leg bone, the meniscus there, muscles that are crossing in the back, the hamstrings, and the calf muscle, and the front, the quadricep muscle. The quadricep muscle is truly king in terms of muscle control of that area. And when there's swelling or irritation in the knee, the quadricep muscle has a program by the nervous system. It tends to want to give out, not use its full strength. And that's a nervous system reflex if there's too much swelling in the kneecap area. One part that's hard to appreciate on this is the joint capsule. We'll talk a little bit about the joint capsule. But that's like that is a connective tissue that envelopes or encloses that joint space that allows for there to be some joint fluid inside of that That joint capsule is present in any movable joint in the body. That joint capsule has some specialized cells that produce the joint fluid. So anybody's heard the expression motion is lotion? When there's healthy movement in the joint, the joint capsule is actually stimulated to produce the joint fluid for your knee. The joint fluid is very slippery, slipperier than the oil we put into our cars. And natural movement is required for there to be a healthy type of oil and lubrication to decrease friction in your knee joint. When there's inflammation, when there's stiffness, when there's lack of muscle control or weakness around that area, that fluid in that joint becomes very sticky. And that is what I think leads to lots of prolonged problems after we get a short-term strain or injury. That inflammation makes things stickier. It doesn't allow for natural lubrication. It's kind of like leaving oil in your car for a long period of time. That's going to have a significant drag on that system. The ends of the bones, bone on bone, wouldn't be an ideal situation. So the body has cartilage in order to provide some decreased friction and movement. We're going to talk about the bone on bone term a little bit and what that means. In a little bit. Any questions on any of this so far? So the one big thing to keep in mind is that a lot of this functional anatomy in terms of quadriceps strength, in terms of joint capsule mobility, are not things that are looked at on medical exams generally or specialist exams, and you certainly can't really see that sort of stuff as well on x-ray, CT scan. MRIs maybe if you're looking for it, but most people don't look for those sort of things. With a little bit of understanding of the anatomy, we can start to talk about some of the contributing factors that might contribute to somebody's knee pain. Knee joint capsule is number one. I put it number one because most individuals who have knee problems have had some sort of inflammation or swelling around their knee, and those knee joint capsules are tight. You'll likely see in the demonstration today an assessment of that and maybe even a treatment of that. It's a major contributing factor. This is a view, kind of a side view, if you will, a cut through section of a generic joint. And you'll see the bone tissue here. The aqua blue is representing the articular cartilage, the cartilage tissue. The red area here is connective tissue that represents the synovial layer of the joint capsule. The area on the outside of that would represent the ligaments that help protect that joint. Every particular type of joint has a particular different type of ligament structure, but this joint capsule contains the joint fluid in there, so you can kind of envision if you have healthy movement that keeps that joint fluid happy and lubricated, and then cells within that synovial capsule actually help to produce the lubrication fluid. In addition, your synovial joints, fluid-filled joints, also have nerve receptor endings that allow you to feel and report the angulation and position of your joints and also speed of movement. So if you have a joint that isn't moving well, it's not reporting the proper information to the brain, and you're not going to be able to feel that and move as well. So it's going to have we call it a neurological effect, or just kind of a muscle control effect, which is a strong consideration for some folks after a while. Yes?
What happens to the joint capsule and the fluid? Does that all get put back together when you have a knee replacement?
So they patch things together. That joint fluid is still there to an extent, but it's not necessarily quite the same, right? I mean, the anatomy's changed, but yeah, that joint capsule is still there. Good question. So individuals who have knee joint capsule problem can be represented by pain. There may be some inflammation there. Stiffness on bending and straightening. Yeah, it's stiff on both directions. That might be an indication that people's knee joint capsule is problematic. They'll certainly have some weakness because their joint can't get to full straightening or bending, so the muscles don't get enough amp up time to get to strong. And everyday activities will feel a little bit off balance. The joint ain't right. It's a major contributor to movement, so movement and muscle control just isn't right. As I indicated, oftentimes isn't really acknowledged or looked at significantly and won't show up on X-ray, CT, or MRI, especially if someone's not looking for it. Only with proper physical examination, and you'll see what that looks like. Quad tendon strain. So your quad muscle, quadricep muscle, that front thigh muscle comes down and inserts into that kneecap. Well, you can get a strain to that tissue there from overexertion. Or if it's not quite strong enough and you're trying to challenge it too much, like, ooh, it's really hard for me to get up steps or get up to standing or get down to a squat, that quadriceps tendon may just be overwhelmed. And on that model, that's represented by this plastic piece here, or this rubber piece here. And you can kind of feel that area here where your muscle doesn't, stops and the quad tendon starts. So that'll be common for folks who might have some pain and weakness in the knee. Everyday activities would be painful. And difficulty, as I alluded to, getting up and down from chairs and stairs, especially going downstairs.
Yep.
There's lots of force that has to go through that kneecap and that quad muscle when you go downstairs. Imagine my poor fishing buddy who he's a solid muscular guy. He's carrying down a solid corridor, down the steps. His tendon ruptured, right? I mean, lots of force. Those things can happen. They happen to really strong muscular people because they're capable of doing lots of power work, right? But frustrating for him. Squatting, forget about it, right? Really tough squatting for these folks. This, squat down to pick something up. So instead of a nice squat like this, they're like, yeah, no, I'm just going to bend at my hips, right? I don't want to use those knees. Quad tendon strain, unless someone's looking at it, generally will not show an X-ray, CT, or MRI. One of the lost arts is apparently physical examination. You'll see what a physical examination looks like, right? So what a physical examination isn't, which is done more commonly than should be, is slapping up an X-ray or an MRI and saying that's your arthritis. When do you want to have surgery? I had a gentleman come to me. He was 53 years old. He was a roofer. He was still doing up and down the ladders, which is fine. I would think at 53 I'd probably rather be estimating, but he quite liked to be going up and down the ladders. And a significant amount of pain, right? So he went to an orthopedist first for his first line of treatment. And the orthopedist took some x-ray and says, well, you got arthritis. We're going to schedule surgery. He lived in a facility where he couldn't just have surgery the next day. So he came to me. I said, well, where's your pain? He pointed to it right here, right? So I did a physical examination with him, and I found out he's got a kneecap problem, right? So we worked with the kneecap within that session, and afterwards he's like, well, my pain is gone. I said, oh. Well, I asked him, well, where'd your arthritis go? Right? Because he still had the arthritis, right? He's like, well, I don't know. He's confused at this time, right? But that requires a little bit more comprehensive examination than just trying to focus on, well, do we see arthritis, yes or no? And will they have surgery, yes or no? And that's unfortunately happens more often than not, and that's one of those scenarios that can frustrate individuals. Like, why aren't you told about other options? So I have a question for you. Cartilage. There are a couple of questions regarding cartilage. So cartilage is articular cartilage that reduces friction. I think everybody knows that articular cartilage can change over time. It's probably not a surprise that most individuals over the age of 50 have some levels of arthritis, right? That wouldn't be a surprise to anybody, right? Cartilage in its healthy form, 10 times slipperier than ice on ice. It's kind of cool stuff. Is oftentimes the only focus for knee pain. Couple questions. Does cartilage actually produce pain? Can your cartilage actually be painful? The question is no. It has no nerve endings, first of all, right? We hear about bone on bone all the time, right?
That's a
Look at-
big one, that's a big thing.
You got
people
bone on
say.
bone.
Bone on bone, bone
Right.
on bone.
So typically no physical examination is done once the x-ray is seen. Is that all there is to the story? So we talked about, does cartilage have nerve endings? No. Other tissues are painful with arthritis. So the other parts of the tissue might be perhaps the underlying bone tissue, maybe some of that connective tissue in that joint capsule, and weakness in the muscles. All those tissues are oftentimes ignored once the x-ray comes in. So a couple more things about bone on bone. So there's an actual rating of how much change there is in that joint, in that articular cartilage. It's called a Kellgren rating scale. You can have mild, moderate, or severe changes, right? And as you can guess, mild amount of change would be just a little bit, moderate amount would be quite a bit, and major changes would be a lot of cartilage change on x-ray, right? And there's objective measures that the radiologist, the specialist who read x-rays, and orthopedists can measure about how thick that tissue is. And the challenge is a couple things. Number one is if you just looked at someone's x-rays and didn't have a conversation with them, and you said, hey, is there the presence of changes on x-ray of that articular cartilage or not? Does that predict someone having pain and discomfort? It does not. It's a flip of a coin. Secondly, the severity of the change on articular cartilage does not relate to the severity of individual's pain. So in other words, there's individuals who have very little change in their articular cartilage in their arthritis, and they have a high level of pain. And there's people that can have absent or nearly no articular cartilage and have no pain. I remember one of my first home patients I did home health visits for quite a while in the early 90s. She was a woman who lived in the house she grew up in, and she was in her 90s. She had a wooden floor, and she was sitting from me to you away, and I was sitting there. And asked her to come to standing, and she stood up, and she had those knees that like really creak, like kind of an eerie creak. Like I can almost feel it to this day, right? Her knees creaked so much that through the wooden floor, I could feel the vibration of her knees. It was just bizarre. And she stood up, and I was just like, oh, you got kind of noisy knees here. She's like, yeah, no facial grimaces. Do you have any pain? No. Well, back then, we didn't know as much as we do now about the research. Like, that surprised me, and it still stuck with me. Like, how can this woman not have any pain, right? Well, we don't fully understand why some people can have very little changes in their knee joint and have lots of pain, and other individuals that can have profound changes in their knee joint and have very little or no pain. But that's what it is. So oftentimes the knee replacements are advocated and advised for individuals, and regrettably anywhere between 15 to up to 30% in some research, people's pain isn't better after a knee replacement. Like, that's not ideal, right? So many people are obviously satisfied with their knee replacement afterwards. We've got a few people here who are struggling after knee replacements, but to know that you can have even 10% or 15% or 20% of the time, you might not have significant pain relief after knee replacement. That's kind of confusing, right? I mean, people aren't necessarily told that a whole lot, and the hope is that everybody has a good outcome. But as we go through these different causes of knee pain, you'll start to understand there's more contributing factors to knee pain than just the presence of arthritis. One of the first patients, well, we'll talk about that a little later actually. Weak quad muscles. So we talked about the front thigh muscles, and here's a depiction of that in red. Muscles are the powerhouse of joints. So Front thigh muscles over time, just like all muscles in the body, if we don't work them ambitiously, they're going to tend to get a bit weaker, right? So after age 25, if we're not involved in some vigorous type of strength training, we're going to lose about 1% or 2% of our muscle strength each year. And that doesn't sound a lot year to year, but you start adding the decades on, and you can start to see at some point there might be some critical loss of strength in muscles that will cause increased challenge or difficulty doing things, and weakness in the muscles can be a contributing factor to knee pain. So this might be common in individuals who have trouble getting in and out of low car surfaces, getting up and down low sitting surfaces, and especially having trouble getting downstairs. Had a patient come to me recently. He says, well, I just don't have a lot of oomph getting off the toilet. Not a lot of pain, just not a lot of oomph, right? Went to his orthopedist, and you can probably guess what his orthopedist recommended. He was a gentleman well into his 70s, right? I don't want no knees. I want to get stronger, right? He wasn't having any pain. I have this expression that meat of the muscles protect painful joints. If you do nothing else with an arthritic joint, strengthen the muscles around it. And oftentimes the symptoms will get a lot better. Question is, how do you strengthen a painful joint that's painful, right? What exercises do you use? If you're going to spend time exercising, where do you start and how do you progress it? Weak quad muscles will not show up on typical X-ray, CT, or MRI scan, only show up with proper examination. There's a couple of techniques we use to assess strength, and this becomes readily apparent as a potential issue for individuals. Is walking enough? Keep knees strong?
It helps.
It helps. But if we lived in hilly terrain, it might be, but it's not. Walking is a very efficient human activity, right? And if people walk, they should continue with it, but it's not enough to protect you for your knees. Only the proper exercise prescription can your knees get stronger, especially when they're weak, painful, and inflamed. You have to be somewhat careful early on so you don't flare things up and abandon the program. It's not getting stronger, only making it worse is oftentimes what we hear with people who exercise on their own because they need some guidance in that. Next cause, misalignment and weakness in the ankles, hips, pelvis, and lower back. Very common. The knee joint actually has some hinge movement, bending, a little bit of twist movement, not a lot. That stuff is important, a little bit of wiggle movement side to side. But above it, the hip joint has lots of movement capability. The ankle and foot are really adaptable. In most instances, when a knee is really problematic, there's likely some stiffness or inability of the hip, lower back, or ankle and foot to move properly. We call the knee a reactionary joint. So unless someone's had direct trauma to their knee in some sort of fashion, that they typically have some sort of associated stiffness in trouble in some of the joints above and below. And if those areas aren't addressed, the knee can't function properly. Without proper functioning movement, the knee is challenged and has a really hard time recovering. So the ankle bone is connected to the knee bone, the knee bone is connected to the hip bone, right? I mean, there's significant legitimacy to that. This might be common in individuals who have like a hitch in their get along, like they just know they're not walking right. Maybe a foot's out to the side, different than the other side, or they develop some sort of limp over time, unsteady on your feet, and just not moving right. Hip tightness and ankle tightness. There are some individuals, for instance, who have knee pain, who frankly have lots of tightness in their hips. Examine the knee. The knee's pretty decent, but that hip is very tight. Sometimes that hip can actually literally refer pain down to the knee. If we're not looking at an area other than the knee, obviously this won't show on X-ray, CT, or MRI scan. Only with proper examination. Kneecap pain, this is really interesting, right? The kneecap, ideally, has the ability, has ligaments that help support it, that's on the sides, certainly has the strong ligament below and the tendon above, but has a series of ligaments here. Ideally, that kneecap would have a little bit of wiggle room side to side, would actually have a little bit of ability to tilt around, and without muscles activating, should be able to slide up and down pretty readily. About the width of somebody's finger, right? So it's quite a lot. When there's a presence of lots of inflammation or weakness or limited motion, these ligaments tighten up. In that instance, you get irritation of the kneecap area because there's too much friction there. So that's called kneecap stress. Also known as patellofemoral pain syndrome, fancy word for kneecap and thigh bone. And this is a side view. So this is showing nice robust hamstring muscles in the back. This is your upper leg bone, your femur. Here's that flattened area of the tibia and the connective tissue of the meniscus. Kneecap here, its purpose is to create an increased lever arm for the quadriceps to be stronger. So as that kneecap forces that tendon to move away from the knee, it actually allows the quadricep muscle to exert more force through the knee, to be more efficient. So there is a fair amount of what we call compression, natural compression that's going to contact that area. So if that kneecap doesn't slide up and down right or has too much tightness right to left, it's not going to be, if you will, optimal or tracking well within that kneecap groove. One of the things that the kneecap does is track up and down in that groove. And if the kneecap is stiff, then the quadricep muscle can't do what it's supposed to do. So you can strengthen until the cows come home, the quadriceps, but if that kneecap doesn't move well, that muscle's not going to get much stronger. Some individuals with kneecap problems, they have what we call a positive movie sign. They sit for longer than an hour, hour and 15 minutes, and their knees start to ache and they start to have to move it. They may have clicking in front of the knee or noise, or maybe when they're younger, they're like, yeah, I used to have really noisy knees, right? Maybe not so much noisy knees now, or maybe the noisy knees now are associated with pain. And on assessment, tightness of the muscles in and around the kneecap. This, unless someone's looking for it, will not show up on x-ray, CT, or MRIs, only with proper examination. It's a fairly common theme. Lower back nerves irritated. Also known as lower back referred pain. So this is an illustration of nerves that supply the region here in terms of sensation in and around the knee, tend to come from the mid-back region. We know it as this area in here, L3, maybe L4, L1. So when there's a problem, and chiropractors might call it out of place, right? We don't really regard them as out of place, but when there's a problem with that vertebrae, an irritation, that nerve can get irritated that innervates in and around the knee. So that's called lower back referred pain. This is common for folks when they have pain with sitting, another common feature. Pain is oftentimes not related to physical activity. Like, I don't have to be doing a lot and it bothers me. And sometimes it gets worse than others. Like, it has a really variable pattern. May have lower back pain at the same time. Most people don't who have this sort of thing. But they may have a history of lower back pain that they may or may not currently remember. And I always say it wouldn't be awful if you suffered needlessly, or worse yet, had a knee replacement or some sort of procedure or persistent problem when this wasn't considered, right? So it makes me think that those individuals who don't have a satisfactory outcome after knee replacement might have something like this to consider. In the clinic, when someone's not making gradual progress, or excuse me, when someone's not making the type of progress that we want, it's either too gradual or it's non-existent, we oftentimes have to step back and think, hey, wait a minute, maybe there's something going on in the lower back, and oftentimes there is. It's a fairly quick fix, quick manipulation or mobilization to the lower back. Their knee pain within session can oftentimes change dramatically. And then, oh, we need to do more of that as well, right? And this is where some studies have shown that 30% of individuals don't get pain relief after knee surgery. And of course, if you're not looking for this, you're not going to see this on X-ray, CTs, or MRI scans, only with proper examination. Meniscus, this is another fascination. Talked a little bit about meniscus as being fluid-filled spacers. You had a chance to kind of see those on the knee model. I'll cut straight to the point. Meniscus typically aren't major limitations to knees getting better, right? They're not the major problem. And why do we know this? Well, so one of the things that happened when I started in physical therapy practice in the early 90s, MRIs became very widespread use. I can still remember it was a big deal to have an MRI show up at a local hospital for an afternoon or a day a week, and then they would truck it to another facility, right? Well, shortly thereafter, and we love MRIs. I mean, MRIs are great. I don't want to live without them, so I'm not bashing MRIs, but what happened was MRIs could see such fine detail into the knee or whatever joints we're thinking of, and there was the assumption that any changes we saw or things that we see on MRI are a cause for concern, alarm, and need to be fixed with surgery. So shortly after the MRIs, arthroscopic surgery became really popular. Arthroscopic surgery for the knees. And they said, well, it's much safer and more effective. And they were focusing their attention on young knees at the time that might have these minor tears in the meniscus. Well, we can go in there and do these basically nip and tuck. Any irregularities they cut out and excise, and very little portals, very little entry. It's not like they open the knee up completely with a large cut. Just these little holes. Go in there and fix stuff up, pull out, not much trauma, and let's see how these people do. The challenge was there was this understanding that maybe they were doing too many knee surgeries with arthroscopic surgery repairing meniscuses. So this medical journal, some of you may have heard of it, Journal of American Medical Association, JAMA, it's a top tier medical journal. They did a study and they said, hey, look, we're going to enroll people who we know have MRI tears, MRI confirmed tears in the meniscus, and we're going to divide them into two groups. And everybody's consented to this. One group is going to have actual surgery. We're going to go in and do the arthroscopic surgery. We're going to do the nip and tuck, just like we would any other individual who presents with that. Other individuals, we're going to go into the knee joint, and instead of actually repairing anything, we're just going to pull a little bit of tissue, or pull a little fluid out, squirt some new fluid in, basically a sham or fake surgery, right? So then what they did is they followed these individuals for 6, 12, 18, and eventually 18 months and eventually 2 years. And they concluded that the two groups of people at each point along the way did equally as well. So they concluded that was a $3 billion waste of money. Mm-hmm. It was shortly thereafter that insurance companies read these too, that there was a requirement that people would have to attend some physical therapy to see if they could get better without the surgery. Oftentimes people were mad because they thought they needed the surgery. I'm not a big fan of insurance companies, but that's one time that insurance companies were trying to help people out, and they're trying to help themselves out. So then what happened is these meniscus grow up. And then over time, question for you is, the meniscus at age 55, 60, 70, are they going to look like a 25-year-old meniscus, do you think? No, they're going to get thinner, they're going to get more frays, wear and tear, right? It's now a mature knee, right? And the condition is called degenerative meniscus. So when someone presents in their 50 plus and they have some pain in their knee, it was very common that, well, we'll fix those knees. We'll go in there and we'll kind of essentially do the same thing, nip and tuck. And then they repeated the same study where they took degenerative meniscus, real surgery, fake surgery, followed them for 2 years, no different between the outcomes, right? So surgery's a little more expensive then, so that's a $5 billion waste of money, and that's concluded. So much so now that a lot of orthopedists don't really do that a whole lot anymore, in part because they have a hard time justifying it, and the research is very clear on that. So meniscus can become a problem, and they can become an issue, but most of the time people can, if you will, work that out and respond favorably to without it. Weak knee ligaments, that's another condition. Weak knee ligaments are much more common in ladies than men, a little more common in younger folks, right? As time goes on, one of the things that does happen is joints tend to stiffen up a little bit. But if someone feels like their knee is sliding around, it probably is, and that's something to be considered, right? We talked a little bit about the ligaments of the knee. In one of the instances, if there's some instability in the ligaments, particularly the ACL, it's one of the times that I actually advocate that people should strongly consider surgical consult to tighten that up, because if that thing slops around a little bit too much and people can feel that sensation, then it probably is, and it's probably going to not be healthy for the joint long term. Muscles can overwork in the area, like if someone's got a sloppy knee and their muscles are always tight, that can become a problem in itself in the cramping of the muscles in this condition when the knee ligaments are weak. Rhetorical question, is it possible to have more than one issue? Yes. It is.
I got them all.
What's that? Is that all?
I got them all.
You got them all? Yeah, right?
Foxworthy joke that goes like that.
Yeah. So almost always. So these are some of the most common in individuals that would likely show up here, right? There's other contributing factors, but these are very common, right? I think we're going to have to include, if you will, failed knee surgery. And, you know, it's anytime you do a high volume of surgeries, and again, a high percentage of those do get better, but there's a certain number that don't, right? And we get a lot of those that don't, and there is hope for those, right? We'll talk a little bit about that as well as we go on. But the important thing is, if we think about all the causes of these knee troubles, I don't know how many I listed, was it about 9 or 10? If there's lots of contributing factors or potential causes, then there's lots of ways to intervene. But the key is to find what's important and what's to be prioritized for the individual in front of us, right? Anybody ever heard the term personalized medicine? So personalized medicine is a new style of term. Rather than treating everybody who has a condition the same way, like let's individualize it, right? And I think you'll see on the demonstration today that there's an attempt to do that, to find out what's going on through a history. We talked about history, that is hearing about the development of the symptoms from start to finish. Was it a traumatic injury that developed over time? When does it seem to bother you? A whole series of questions. Are there other things going on that may trigger some medical issues? And then tailoring the examination and the treatment to that individual based on a priority list that's important for that person. And that's what we call personalized medicine, as opposed to your knee's bad, let's inject it. When that no longer works, let's schedule you for surgery, which is fairly common. Questions about any of that so far? All right. So, this is the favorite part of the program. We call it 5-Minute Miracle. So it's an opportunity for us to see what examination and treatment to a problematic knee might look like. So I have a question. Who all has a problem simply getting up and down from a chair here? Stairs?
Sometimes.
Stairs, okay. So, you're already in our sphere. I'd like to check out your knee if that would be okay. Would we be okay to take a look at your knee for? Okay. So would you be able to change into a pair of shorts? All right. So it's a little different. Today we're looking at somebody who's had knee replacement before. I've never done this in a 5-minute miracle here, but I think this is good. So tell me about the difficulty you're having with your knees.
The muscles across here seem real sore,
Okay.
like getting up from stairs, downstairs, up not so bad, down hurt.
Okay.
This one worse than this one.
And
This was this one was in April 13th, and this one was on the end of June.
okay. So you feel like they're weak or they're painful?
They're painful,
Painful.
and they're weak.
Got it. What were the symptoms that you had prior to surgery?
My knees were bone on bone for a long time,
Mhm.
5-10 years. If I'd go upstairs or climb on a ladder or something, you could stand like 4 feet away from me and hear my knees crunch and crack. And they hurt like crazy.
Got it. Okay. So the pain's reduced, but you're not back to where you need to be.
Yeah. So my knees itself don't hurt, it's just the muscles here.
Okay. Okay. So I'm gonna lower this to the floor so we can have, or not to the floor, to its lowest setting. And we'll challenge these in a couple different ways. I'll see how it is that you come to standing and maybe look at a squat. And let's see how that goes for you. Fair enough?
Okay.
All right, so come up to standing. Any bother with that?
Pulls,
Pulls? Okay. Mild, moderate, or severe pulling?
not real bad right now,
Okay.
this time.
And have a seat.
Sometimes
Have a
it
seat
gets worse.
slowly. How about now?
Pulls a little bit like right here.
Okay. And now come to standing once again.
When I stand, it pulls up higher.
Got it. Come forward if you would. All right, so now what I'm going to have you do is stay on your feet so that your heels and toes can stay on the floor. I want you to go down slowly into a squat. What type of work did you do?
Well, mechanic.
Mechanic, okay. Go into a squat to the extent that you can.
That's pretty good.
And come back up.
That's right.
That pulls.
Pulls and pulls at the bottom there, right? I mean, he gets a nice depth of squat, right? But he's not satisfied. You still want to get up and down ladders and be safe going up and down steps, right? We can certainly have him do a step down. I think we're going to get the similar effect with the sit to stand off the table here. So if you don't mind, have a seat on the table. Had a fairly routine recovery from both surgeries. Okay, slide back a little bit. All right. So you get sore kind of in these areas here. Is that correct? In through here,
Here is where it's sore.
in through here.
Yeah.
Okay. As I press in there, any bother?
No.
Okay. How about in through here?
No.
So we can feel the connective tissue in and around the scar. Not a lot of tightness there. This one's a little more recent. Some tightness there. Sensitive there at all?
No.
Straighten out this knee. Hold your knee straight. Don't let me move it. Don't let me move it. Good. Leave that go. Any bother with that? We'll challenge that a little bit more. Go ahead and push your leg up to straight. Push, 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 push. And leave it go. No bother there.
No.
Once more. Push, 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 push. Fair amount of power there. That does not bring on any of those symptoms. Is that correct?
Yeah. No, it doesn't hurt me.
Straighten up here, please. Hold your leg straight. Don't let me move you. Any bother there? Allow your knee to bend. Push your leg up to straight. Any bother there?
No.
Okay. Would you mind slipping off your shoes? So good shoes for winter there. Good grip on the bottom. Do you have some after surgery exercises lying your back?
I did most of the therapy at home.
All right. Let your leg relax here. Pull your toes way up towards your head as far as you can. We're going to measure your ankle mobility here. Ankle mobility looks pretty decent. I'm predicting a little bit more than 15 degrees. Good. And this side, when did you retire? Or are you retired?
Yeah,
How long are you retired?
8 years ago,
8 years ago. Okay. What do you like doing in your free time now?
fishing and hunting.
Nice.
I wasn't able to do that anymore.
You back to that?
Yep.
Somewhat? Okay. Allow me to move you. Any bother there?
No,
So good bending.
you can feel it crunching.
You're pretty ambitious about your exercise,
Mhm.
right?
My wife kept saying I was overdoing it.
I'm gonna grab something here, just right behind you. Excuse me. Careful the corner here on your back. You thought you were overdoing it?
Yep.
In what way? Push your knee down?
Trying to be too aggressive, do too much.
Yeah.
Too fast.
So he strains his knee a bit beyond straight. That's good. Here, push your knee down to straight. Oftentimes people after knee replacements, they don't get their full motion back. Push your knee all the way down to straight. This one's about 5 degrees from fully straight. I don't know if you can see that.
Put that under the heel more.
What's that?
To put the
Slide up a little bit more. He's got a competitive edge, so we're going to retest that. He does indeed get a bit further than that. Turn your heel up towards the bum. And that's more than enough mobility there. Good.
Yeah.
Bring your leg out to the side, hold it out here, don't let me move you, don't let me move you. Try that again, hold it out to the side, don't let me move you. Is that very strong, do you think?
No,
How about this one? Bring this to the side, hold it there, don't let me move you. How about that?
yeah, I think that one's stronger than the other one.
Bend your knee up, please. And the other one up. Lift your bum in the air. So this is a little different type of exam. Cramping the hamstrings.
Yeah.
That can happen. You want to try that one more time? So
No.
Tell you the truth.
keep breathing, keep breathing. Now keep your bum up. Lift one foot off the floor. Keep your hips level. Is this an exercise you do? Quite a bit of cramping there.
Yeah.
Sometimes it just happens. So yeah. So I'm going to have you lie on your side facing out there. What we're going to do is we're going to facilitate a couple of his muscles, right? Side hip muscles. So we talk about the integration of the hips. Bring your legs straight back, like that. Good. Keep your hip forward. Raise your leg up towards the ceiling. That's it. Back down. Go ahead and raise that up towards the ceiling again. Back down. We're going to bring this leg slightly back and keep doing that. I'm going to challenge this here. Go ahead, up. What I'm doing is there's a side hip muscle called your glute medius. It's the muscle in the back pocket area. Up to the side. When people perform any leg action, the hip muscles have to activate, particularly the side hip muscles. They're oftentimes neglected. Go ahead and continue a couple more times. So what I'm doing now is a technique to help stimulate them and get them back to some semblance of strength. So that heat, or awakeness, I should say, alertness. One more time. Hold it there, hold it, hold it. And do some stretches there. Hold it, hold it, hold it, hold it. Good, thank you. I'm going to have you lie on your other side.
How old are you?
71. Gonna be 72 in February.
Straighten the legs out.
Do you still have the cramping now or no?
No.
Okay.
You're doing well.
And we'll straighten this leg up here. There we go. Back down. We're going to do the same thing on this side. Go ahead. Continue. Roll that hip forward a little bit. There we go. Continue. right here, we're trying to activate this muscle here. It's nice because I can lean my weight into this, right?
Mm-hmm. You're leaning your
Good.
weight on his foot, right?
Yes. All right. Lie on your back. Have a seat, if you would, swing your feet around. So oftentimes we can start to make some determinations about what this might look like before and after a given treatment. He didn't have a lot of stiffness in his knee joint or his knee joint capsule. The scar tissue, pretty decent healing. Relative to how much demand he has on his knee, his quad muscles still are a bit weak, right? His hip muscles aren't quite as strong as they could be. We're going to facilitate his quadricep muscles too, try to find a way to boost them up a little bit. So what I want you to do is right here, just hold yourself right there. Don't let me move you. That's it. Hold, don't let me move you. Don't let me move you. So we're going to do this alternating forward and back. This is called rhythmical isometric contraction.
You just want a better workout.
What's that?
You just want a better workout.
I'm not being bashful here, am I? No.
No, he's pushing.
So at times when people have lots of sensitivity and pain, obviously we're not going to be able to do this session one, right? So we individualize this to the person. Hold. Okay. We typically think of strength development as something that takes time. There's short-term and long-term benefits of strength training. Short-term benefits are when the muscle to nerve connection gets stimulated. And that can happen here as the muscle and nerve connect from the spine to here. It can happen in the spinal canal. It can also happen from the brain down. So sitting to standing uses more than just the quadriceps. We're determining whether or not this stimulation to his major hip muscles and the front thigh muscle might contribute to a better sit to stand. That's what we're going to be looking for, to offload some of that pressure. If you would please put on your shoes again. All right. Got a little bit of workout so far. All right.
So far. Okay.
Let's see what it's like for you to come up.
Interesting term,
Let's
huh?
see what you think. What do you notice now?
Better.
Nice.
Quite a bit better, it feels like.
Lovely. I like that. I call it, huh?
Yay.
Nice work. Thank you, right?
It's a miracle.
I think so, right? I mean, so this is the cool part of it, right? I mean, so here's the thing, like, either it's going to help or not, right? So that validates the thinking, right? So the process is this, right? Like, typically I don't work with in these
Replaced.
settings like a knee replacement, because who knows what we're going to find, right? But we go through the process, right? Normal process of healing and recovery. Left with some residual weakness that's still a bother. Going downstairs would be nice to test before and after. We didn't do that, but that's what we want him to be able to do, so he can go down steps one foot after the other and good muscle control. So he's confident about that. A lot of people in their retirement, they have various ideas of what they want to do, right? Some people are happy going out to eat, going to the bingo halls, and going to the fireside theater. Those are all great things. People should do more of them. But other people want to still be more active. Waterfall tours, hunting, fishing, being active up and down, right?
Cutting firewood.
cutting firewood, that sort of thing, and that's awesome. So it's what is important to that individual, right? And we're happy to be able to adjust to whatever, right? So he didn't need a lot of kneecap mobility stuff. He didn't need joint capsule stretching. He didn't need ankle mobility stretching. His hips are very flexible, right? But what he didn't have was a high level of strength. At first glance, you'd say, oh, the guy's got good strength, you know? Manual muscle test, it's not very sensitive, right? It's not very sensitive for two reasons. Number one is I can't exert the same type of forces through that front thigh as with my hand test as I can with him doing something, right? So that sit to stand is a much better test of his strength. And clearly it was painful. It was somewhat bothersome. Number two, it can't tell what the other muscles are doing in combination, right? We just can't predict that. So most individuals have not enough tension or capability of contraction there. And research is becoming pretty clear that for kneecap troubles, for instance, and other knee troubles, that when we strengthen the hips, people get better outcomes, right? So we don't just focus on where the yowie is. Like he could have that massaged all day long. We could put an ultrasound motion on there, we could laser that all day long, we could do a whole number of things to that area. But that's really not where the problem is. The problem is there's not enough firepower in that muscle because he hasn't had the specificity of training for that muscle to adapt. He's a strong dude.
Yeah.
Right?
I
There's a
can see
lot
that.
of muscle capability that's beyond there. So he's got great genetics, he's been active his whole life, and yet he's still going to have capacity to improve. So I like that. It was more of a muscle conditioning, muscle facilitation type of activity, right? We're not married to a technique. Like we can manipulate and mobilize tissues, we can massage people, we can hook people up to electrical stimulation and you do dry needling, we do all that sort of stuff, right? And at times early on in a plan of care that's needed because the nerves are so dang sensitive that we can't tax them like we did him, right? I mean, that's an unusual first encounter for someone who has, not unusual, but it's not typical. What we do is when someone has pain and that sort of level of weakness and sensitivity, then we gotta calm that sensitivity down so that we can get to this point where we can advise on conditioning exercises, right? So if you never saw me again, yeah, you could strap on some sort of resistance band in your legs, you do that sort of thing, and maybe do some isometrics there, right? I mean, if you did nothing else, you'd probably be a lot better for it, right? But you're really active, I would still recommend, hey, maybe you get some ideas of what you can do to progress this to higher levels of strength so that you're sure to get that descending stairs, which is the most aggressive activity that you're going to do, and maybe floor to stand, right? Getting up and down from the floor. Those are probably some of the more vigorous things that someone needs to do and needs lots of force production. So we want everybody to get to that capability so they can get their butt near the grass when they do a squat, right? Because that most people should be able to do that with good muscle control. You're like cringing, like that's not even possible. Like,
No way.
not believing it, right? Most individuals get to that point, right? You're like, you're
Not
still
that
not believing it, right? But that's just an indicator that someone has the muscle control so they can get in and out of a car and that they can get up and down stairs reasonably, right? Things that most people should be able to do, so there's these things we have here. I've got slides for some of these things, but I'll talk this through. The 4 phases of plan of care, you see it over here. First phase is we want to relieve pain and inflammation, okay? Like I talked about, we've got to calm things down. Second phase would be to correct some muscle imbalances and things that might have led to it. Stiffness here, tightness there, not enough muscle power there, and then we want to strengthen within that newfound range is the third phase. The final phase is what we call preservation or building in resiliency, right? Building enough capacity so he can match his strength and ability with what he wants to do. Maybe he's someone who wanted to do some cross-country skiing, or maybe somebody who wanted to do some hiking. Well, then we need to identify what sort of things people want to be able to do, help him match that, and most of the time it involves some sort of strengthening program, right? Some sort of program to get the meat of the muscle stronger, because those things are going to want to get weaker over time if they're not challenged, right? So we follow several phases of plan of care in order to help get to that point. Any questions about that?
All day rocking chair doesn't do the job, does it?
Doesn't do that job, right? That's for sure, right? So So super, well, thank you so much. So there's some individuals, there's opportunities for other types of interventions here too, I should say. One of them is dry needling. Dry needling is, anybody heard of dry needling? Yeah, many of you have, right? So dry needling is highly effective for painful arthritic knees. We're pretty happy using hands-on work to help calm things down along with progressive exercise. That is the mainstay of what we do for most individuals, right? In different proportionalities. Early on, maybe a little more hands-on work to calm things down. And then introduce the exercises early, progress them over time so they're more robust and help people develop increased strength. When dry needling is added, so in other words, if someone has the hands-on work and exercise, you compare those with folks who have hands-on work, exercise, and dry needling, the folks that have dry needling added to their plan of care in research projects and what we see in the clinic, they get further pain relief. They get stronger, they get less reports of pain and lower use of pain medication. Dry needling is just the use of those acupuncture needles. We help people without it, but I think people should know about it on the front end so that they can make a choice as to whether or not they want to have that service done. I generally recommend it, right? But
So where
people
would you
can choose
put it for the knees? Would it
well, for
be
the
in
knee, there's
thigh?
a number of places we put it. We put it in the joint capsule. We put it in those front thigh muscles. We put it potentially around the kneecap. A couple different strategic areas that they would go into.
Not necessarily up here.
Sometimes they're up here, but generally it's around the knee, right? So what they did is they found all the literature that showed positive outcomes from acupuncture, and they found out what spots they tended to use in those studies, and then James Dunning, Dr. Physical Therapy, went back and traced, well, these were the physical structures that those needles went into. Let's design a protocol in which we use the commonly used needles and then run the study and see how we can help people with arthritis. So that was that. So again, it's a worthwhile conversation. Generally, dry needling is not covered by insurance. We talk about that up front. In 2021 and before that, we were charging $75 per session for that. That cost dropped to $29 for 2022. In 2023, it'll go up a bit. We wanted more people to have access to it. Coming out of the pandemic, there are a lot of people who are having troubles, right? So it's an extra charge because insurance companies don't reimburse for it right now.
But I can attest to its benefit for my neck. After the first treatment, I didn't have the stiffness and soreness.
We were in an auto accident in June, so we both had whiplash. And so you've had some real good.
Real good sessions with
For
the
sure.
dry
For sure.
needling, yeah.
Good. So then what I say is, hey, you know, when's a good time to consult a doctor or PT for issues? I think obviously if pain is limiting your ability to do things that you want to be able to do, particularly if it's involving those important daily activities, getting up and down from chairs, getting out of cars, being able to walk to shop, that sort of thing, but also being able to do the things that you want to be able to do when it comes to your lifestyle, whether it's travel, whether it's some sort of athletics, right? And if you're worried about it getting worse and you're not seeming to be on a pattern of getting worse, good to get a look here, right? So one of the cool things is being a doctor of physical therapy is I get to use all the best tools for conservative intervention, exercise, muscle work. For some folks, they have painful inflamed muscles. We do deep tissue work with massage tools to get some of that fluid moving out, to get some of those muscles loosened up and get some pain relief. All with the intention and combined with the hands-on work, the joint mobilization manipulation to calm nerves down, so we can build tissues back up and get them stronger again to do the stuff that you want to be able to do. So.
For people who have arthritis, especially rheumatoid, there's a change in the diet that can be done. I don't know if you've heard of it. It's avoiding nightshade vegetables. They're associated to a poisonous plant that I can't think of it right now, but eggplant, tomatoes,
Peppers, bell peppers,
all kinds of peppers. potatoes that have a white flesh. The purple flesh is okay. It's called Peruvian blues. What about the sweet potato? I don't remember.
Tell me not sweet
No,
potatoes, I
I'm
love sweet potato pie. There is increased understanding of inflammation and being a contributing factor to issues, and one of the things that we forget about is that exercise itself is anti-inflammatory, right? So getting into an exercise routine, but also a more healthy diet. And most
You
people know
eat that
that
pumpkin pie then, and
Sweet potato pie.
sweet potato
Easy,
pie,
easy.
and then do what you need through the exercise,
For
right?
sure. So anyway, I'm here to answer questions, and one of the one more thing. At the end of a plan of care, like when we see somebody, we want to give them a couple of key things they might do every day to keep mobility and flexibility. Just as importantly, give them a couple of ideas of what they could do to keep strength progressing or keep that strength long term. That might simply involve 2 or 3 days a week do these handful of strengthening exercises. Someone really wants to be ambitious and are much more active and want to get at the why or some sort of fitness routine. If they want a more involved program, we can help them with that. But what are the 2 or 3 essential strengthening exercises someone needs to stay strong? And what are the couple of flexibility things that we would be done on a regular basis to keep it simple and tight? So not a big long list of things that takes 30, 40 minutes. That's ridiculous, right? So that's one of the things that we want to. Now, if people decide to do that, that's on them, but we want to make sure we give them the tools to keep it that way. So in your information packages, there's a couple of, obviously you saw the list of testimonials of some folks from our Google page. Some very interesting cases, but we can talk about them, but certainly from here, if you want to get a look at your particular issue, have an opportunity to see what the solution looks like for you, we're happy to have you come on in for a free consult, complimentary consult using your discovery visit. There's times that are posted along the wall here, couple Fridays, couple Thursdays.
So
and
starting here is the soonest available, and then they go to later in the month as you go throughout the room, and you just grab the entire time slot, and you can bring it up to Robin or I out front there.
And then after that discovery visit, we can let you know what's going on in your circumstance, what the solution looks like in terms of what it would take to get to your level of recovery, and we can let you know what your cost is ahead of time. Most people want to use their insurance, so we can do some insurance pre-verification, and let you know what it looks like in terms of cost for time and money for a fix for you. Yes?
Do you do multiple issues at one visit? Like if it's a shoulder and a knee, or?
Yes, we do. I mean, I'm a little hesitant just because if someone's like coming to us, oftentimes we ask them to prioritize their problems. Like if we're chasing after 3 or 4 different areas, and we don't want to dilute the main thing they're coming for, but oftentimes we'll treat 2 or 3 different areas at once, yeah. Sometimes I'll have conversations if someone's really involved and they really need a lot of help. I'm like, look, we could treat a couple of their areas, but let's manage your most important area first, get that underway, and then we can address the other area as it comes up. So, great question.
So if I'm not currently having an issue, is there a benefit?
Well, if you're doing something like a lunge, right, and you're not stable with that, right? A lunge is what you need to pick up stuff off the floor. It's what you need to do some household management, some yard management. That's significant enough to get a look at and see if there's something that can be tuned up somewhere. And that,
I mean, so if sometimes it doesn't bother me, and then every once in a while it does.
Typically in an examination, we can adjust it to enough vigor, right? Like I had to go.
So even if it's not bothering me at the time that I came in, you'd probably still be able to see something.
Yeah,
Right.
our tests are sensitive enough to pick up stuff. Right. And if not, we'll be like, I don't know. Come to us when it rattles and rolls. But usually we can tease it out. Or if someone comes to us and they've got a pain condition, they take some over-the-counter pain medication or something like that, or something they take for pain relief. We can our tests are sensitive enough to get to provoke symptoms, even if they're being controlled with some sort of
Right.
supplementation. So cool, yeah, so I'm delighted you're here. I'm available for questions. I want to respect people's time. So thank you for your attention. And if you, Erica can kind of guide the process the rest of the way for those of you that want to move forward with a discovery visit session.